Hoàng trước ạ. So we
the co-host to admit the people already, so we don't have to bother about that. It's just that it will be a disruptive of the pop. Sure.
Hoàng ơi, cho full screen giùm Hoàng.
em
There was an option.
nói vào đây được.
This.
Em chỉ cần mở.
Dạ.
It's okay.
Okay.
Hello, everyone.
Hello.
My name is Dr. Huang. I'm from liver surgery unit, Ho Chi Minh City Hospital. I want to share my first case today. The patient is male, 7 years old. Accidentally finding of HCC during health checkup. He had no XCV or XBV infections, no cardiovascular disease, no diabetes, no prior surgery, no smoking, and no other family cancer history. On physical examination, they have ECOG1 and no lymph node detected. The laboratory tests show that on the liver, the tumor marker the elevated. The patient have the HCV positive test for HPV and
Hi, we couldn't hear you.
Yeah, I'm sorry that we couldn't hear from you Hoàng. Hoàng ơi, không nghe gì hết Hoàng ơi. So please.
hello. Can you hear me?
Yeah, we can hear you now.
Yeah, we can hear you now.
On investigation, the patient have the tumor markers elevated and positive test for HPVs. The patient have a normal liver test. The type is 5 points. On echography, there are poor androgenic mass about 77 and 66 millimeter, no calcification, no hypervascular, no lymph nodes, and no splenomegaly. And the tumor was suspicion for HCC. On MRI, there are two mass in segment 7 and 8 measuring about 43 millimeter and 67 millimeter. Enhancement on arterial phase with a west out, no extra hepatic spread, and no vascular invasion. And here you can see some of the pictures of the patient MRI. The diagnosis is XCC, BCLCP, Chi-H, and HPV positive. And thank you, that's my case. And so we can have some discussion.
Xin mời bác sĩ Huy cho coi dùm hình ảnh. Xin mời bác sĩ Huy. So I would like to invite Dr. Huy is from the imaging department. Could you show us the images, the MRI image of the patient?
Excuse me, but I have just received this case recently. Actually, I only have images for the next case, but not this case because we have some problems with our PACS system.
Yeah.
So I think it's fine with the images provided from the surgeons.
Okay. So now Hoàng ơi, xin chiếu lại cái ấy coi. Sorry, sorry that we have the problem with the images, but now the discussion point for us is how we can deal with this case is the SCC of the right liver with Chibuk A, and also he's 70 years old if I remember correctly.
Right.
So the point of the discussion whether we could perform the surgery or any method like TACE in combination with systemic therapy or TACE and after that surgery. So
Okay.
we would like to hear your opinion about the
Yeah.
method of treatment. Yes.
Yeah, thanks. Very nice presentation. So this is a 70-year-old gentleman with hepatitis B, Charles Pills A. So he has 2 tumors in the right lobe. The liver is minimally cirrhotic, so the liver function is still pretty good. The future liver remnant of the left lobe is sufficient. I think it's more than 40%. And there is no vascular invasion. So technically speaking, this patient can be resected. But if you look at the tumor, it is more than 1 tumor, it's 2 tumors at least. And then the volume of the tumor already makes it beyond up to 7. So while this is technically resectable, the long-term outcome may not be so favorable. Patient's OS will be less than 5 years, and the recurrence-free survival may also be short because there may be recurrence. So the consideration here is whether we can do something more to improve his long-term overall outcome. And of course, that can be done in 2 ways. Of course, you can firstly consider giving adjuvant after surgery, but as you know, there's no proven adjuvant therapy in HCC today. The other way is, of course, perioperatively or preoperatively, can we change the biology? And of course, for a patient like that, one way to change the biology and to improve the long-term outcome is actually to treat the patient with yttrium-90 radioembolization first, because that has been shown to be able to reduce the volume of the tumor, but not only that, to change the biology of the tumor so that the long-term outcome after resection will be better. So my suggestion for this patient would be that if we want to improve the long-term outcome, because it's already beyond up to 7 and this is not a solitary tumor, we should treat the patient with a high-dose yttrium-90 on the right lobe, which is very safe because the left lobe has no tumor. And following that, after regression, maybe at 3 months' time, we can consider resection of the remnant tumor. So that would be my suggestion. Happy to discuss.
As you know that at our hospital we could perform the surgery and also the TACE and also systemic therapy, but we don't have the Y90 yttrium-90. Usually we send out to another hospital in the northern of Vietnam, in Hanoi is Bat Mai. But actually, very few cases performed there. Actually, do we have any other alternative methods?
Yeah, so I think the other thing is there are groups that are testing systemic therapy before surgery. So as you know, the term is really conversion therapy or downstaging for surgery. And you know, there are series where you would give either a TKI. So people have tried lenvatinib. So lenvatinib response rate is not too bad. It's under 20%, but it's still quite decent. And of course, the Japanese have shown that atezolizumab and bevacizumab could be a good way to downstage. I think that study has been presented by Professor Kudo It's called the ABC study. It's a Bev conversion study. And in that setting, he has shown that a subset of patients who do very well can eventually have surgery. In fact, a subset of patients don't even go for surgery. It's called drug-free. And then, so that's actually drug-free, but no surgery done. So some of these patients do well because in BCLC-B, the response rate of Bev is much higher than just 30%, which is in BCLC-C and B. So that was in Brave 150. So I think that's, I'm not sure at your center which is your favorite systemic treatment that you use, but it would be interesting to hear from your side what systemic therapy is most often used.
Yeah, at our hospital we have Atebef and also lenvatinib, but for the conversion therapy we just started several months because after having heard the presentation of Professor Kudo and also your Professor To in ESMO Asia last year, so we think that this is better to have some cases with conversion therapy like this case, because we are very worried about the very high old age patient, especially
Yes.
the one with the cirrhotic liver. Because I on the imaging on the MRI, I don't think that the remnant liver after resection have enough tissue to have enough the function for liver function, because the normal tissue sometimes you can see that this is very rough. It's possible with these cirrhotics. So I think that the conversion therapy could be one of the reasonable choices, but the Y90 is very difficult for us. But the question for Professor To is, for Professor Cho is, how can we design the resection border in order to consider that the remnant liver is enough to have the full functioning? Because we have experiences of some liver failure after the resection. So
Yeah.
how do you do at NCC? Thank you.
Yeah, thanks for the discussion. So for a patient like that, if we want to consider resection, the first thing we do will be ICG retention test. As you rightly pointed out, this patient is cirrhotic. So although the patient is Charles-Pills A, the data is not granular enough for us to decide that the liver function is adequate. And for patients like that, we will routinely do an indocyanine green retention test. So for a major resection like that, the indocyanine green retention test should be less than 14% at 15 minutes, then the liver function is adequate. The other thing that we would do is to do a CT volumetry or MR volumetry to see what the future liver remnant is going to be. So with a liver that is cirrhotic like this, even with a good ICG, we would want to have a liver that is more than 40% future liver remnant. So if these two conditions are met, the patient may be resected without increased risk. But the other consideration I've said earlier is that conversion therapy is probably a good idea, because even if we can resect these patients safely, the natural history will not be so good because this is beyond up to 7 and also not a solitary tumor. So while resection can be considered and you can do ICG and CT volumetry, I think a good recommendation for this patient may be conversion therapy, either through systemic therapy or through Y90.
Yeah, thank you very much, Professor Cho. Xin hỏi là các anh chị bên khối ngoại, bác sĩ Nhật Minh với bác sĩ Hoàng và các bác sĩ nhóm T, các anh chị có ý kiến gì không ạ? Các anh chị có ý kiến hay có câu hỏi gì không? So do you have any question from our team, from surgeons and also TASE team, please? So any question, please?
I just wanted to ask you for your hepatitis B carriers. on treatment, do you routinely give antiviral agents?
Yes, we do.
Okay,
Yeah.
that's okay. Just curious. Thank you.
Yes.
And in terms of systemic therapy for advanced unresectable liver cancer, what is the most common systemic therapy that is used in Ho Chi Minh?
So for the first line, we have Atebef and also lenvatinib.
Okay.
I myself treated sorafenib sometime before, but now actually we drop out of this for some Chibuk B. We could consider monotherapy with Keytruda, but actually it's very awful for after that. And for
It's hard.
the PCLC group C, we stop.
Yes. No,
Yes.
yeah, it's very similar to our practice. Thank you.
Yeah, but actually, if I heard it correctly, by the beginning of next year, we have a strike here. But now we just have the durvalumab. We don't have the tremelimumab in our hospital. And for the nivolumab and ipilimumab is very expensive, and we don't have a Opdivo here also. So now our first line treatment is the Atebef, or lenvatinib. In some cases, is sorafenib or Keytruda.
No, I think it's completely reasonable because, to be honest, we have long-term data for Atezolbev, in terms of overall survival. And in the Asian analysis, the survival is even longer than 19 or 20 months. So I think it's a very good combination. So unless the patient has bleeding risk or, high-grade varices, I think it's a very good combination. I mean, to be honest, the STRAT regimen is good, but it's also expensive in Singapore. And I think we are waiting for the approval of these drugs to be inside what we call the cancer drug list. Because once the patient's combination is in the standard drug list, the government will step in and help to subsidize the cost of the drugs. And the pharmaceutical companies will also reduce the cost. So, but before that, it's expensive for us as well.
Yeah. So thank you for the information. So for the combination of Atobef, here in Ho Chi Minh City and also in Vietnam, usually we have the bevacizumab subsidized by the insurance, but not for the IO, the Keytruda, the atezolizumab or durvalumab. The insurance won't
Dạ
pay
đó sau thế mua
for the
suy gan
treatment.
thận nhanh chưa?
And for the combination with Atebef is usually around 3 to 4 thousand US Singaporean dollars for each cycle. Estimated in Vietnam dong is around 60 million Vietnam dong. And for
So that's expensive, yeah.
yeah, it's very expensive. And for
Dạ đúng
lenvatinib
rồi
is
mà tại
around
vì xuống mình
40
với lại ngay
million
cả
Vietnam dong. It's
ngày
just
hôm sau
around
sáng thứ bảy buổi buổi sáng em mua coi là kiếm
2,500
dẫn đâu không có dịch này
Singapore
cùng phát
dollars.
về.
Okay.
Dạ,
I think
mà
every
vì,
country is different.
men gan thì tăng rõ, tiểu cầu giảm, nó giảm nhanh ghê. Vô suy
Các
gan,
bạn ơi,
suy thận.
nhờ các bạn tắt giùm các cái mic của các bác sĩ khác đi ạ. Yes. So
I I just came back from Bangkok to give a talk at Best of ASCO. Not meaning to say too much, but it's also in Thailand. Sometimes they even resort to FOLFOX because the cost of sorafenib and lenvatinib is not subsidized in Thailand. So I can understand their challenges, especially in maybe the rural parts, of Thailand and other countries.
Yeah, thank you. Như vậy thì các
Là
anh
lúc trưa thử anh, buổi trưa có thử.
cái bạn nào có cái chữ iPhone của Đức á, xin vui lòng tắt cái tiếng giùm ạ.
Không cũng không bình thường nhưng mà hình như là 10 chấm hay sao?
Các em ơi, các em hỗ trợ về cái kỹ thuật giùm anh tắt giùm cái mic giùm.
Dạ tắt rồi.
Rồi. Xin mời bác sĩ Nhật Minh với lại bác sĩ Hoàng có ý kiến gì không ạ? Ý kiến gì về cái ca này không ạ các anh?
I have one question. In case the patient have not enough the future liver remnant volume, in your the institution, do you do the bottle vein embolization or the procedures like the two-stage hepatectomy. Can I ask about your opinions?
Yeah, thanks for asking. So many years ago, if the future liver remnant is too small, we would do portal vein embolization. But recently, for the last 10 years, because we have been using Y90 yttrium, we find that the yttrium is a better option because the yttrium will both control the tumor as well as cause compensatory hypertrophy of the contralateral lobe. So usually between 3 to 6 months after yttrium, the other lobe will be quite hypertrophic. And in our experience, the results is actually maybe better than portal vein embolization because the tumor is also controlled at the same time. So we use Y90 both to reduce the size of the tumor as well as to hypertrophy the contralateral lobe. So because we use the yttrium so often today, we do not do ALPS and we very rarely do portal vein embolization.
Thank you. Any question, Dr. Wang and Dr. Nhật Minh? Any question, please? So if you don't have question, I will go to the second case because we are running out of time.
Sure.
Yeah. So we go to second case. Sorry. Các bạn kỹ thuật của bên đó nhờ hỗ trợ mở giùm cái case giùm mất thần này lại mất thần. Bên này sao không mở được? Okay. So for the second case, okay. Các bạn kỹ thuật ở bên đó có thể mở dùm cái lên toàn màn hình được không ạ? Okay. Yes, please. For the second case, this is a 68 years old male with chronic hepatitis B. So please next slide.
Dạ,
So
xin
I can control this slide here.
Bác Thuận share màn hình giùm em ạ. Bác Thuận chưa share ạ.
Share màn hình. So. Ở đây anh bấm toàn màn hình nó không chịu em. Ở đây anh bấm toàn màn hình nó không chịu.
Dạ, bác Thuận cho em xíu.
Không biết làm sao. Cái bộ phận kỹ thuật hôm nay không có bên này hả em? Anh bấm full màn hình không được em ơi. Biết tại sao? Thôi được rồi, em bấm chuyển slide giùm anh bên đó đi. Em mở slide đó,
em bấm cho bác Thuận từ bên cơ sở 1 luôn đó.
Đúng rồi, em bấm đi.
Bấm sao? Để.
Thường đó là tại vì khi mà nếu mà mình có nhiều người attending quá đấy thì thường cái màn nó sẽ hơi chậm một tí, cho nên là anh nghĩ là bấm chậm lại.
Không, cái này không phải do mạng đâu, tại vì bấm rất là nhiều lần nó không lên.
Tại vì thường em thí dụ mà em có 5 người attending thôi là đã thấy chậm máy rồi, cho nên là thấy bác Thuận cái chuột cũng di chuyển khá chậm ấy, cho nên em nghĩ là do mạng lắc ấy.
Need to do the screen.
We can have a full screen, but actually we could move. Okay.
Only full screen.
Okay.
So we could move.
Sure.
Yeah.
This is our patient. Yeah, I could. So 60 years old. So his male weight is 48 kilogram. His ECOG is what? He has the medical history about chronic Hep B for 20 years, treated with Hep S, is the tenofovir. He have a GERD, he have a benign prostatic hyperplasia, no hypertension or no DP. So in November 2018, is the initial analysis of SCC with 2 cm in segment 7 treated with RFA. In December 2023, SCC recurrence with 3 cm in segment 6 treated with RFA also. In March 2024, with multifocal SCC, largest tumors ACM in segment 5 to 6 and 7, treated with hepatectomy of segment 5, 6, 7 and cholecystectomy. In May 2024, the SCC recurrent at the resection margin, which is segment 7 cm, treated with TACE, and after that we decide to give lenvatinib 8 milligram for 1 month. But after that, in June, just 1 month later, June 2024, AFP level rising so quickly. So we decide to re-evaluate with the CT scanner. We show that this is multifocal SCC in 2 lobes, segments 8 and 3 left lobe foci, with persistent elevated AFP and BK2, treated with atezolizumab till 2 months later, August 2024, after 3 cycles of atezolizumab, he still have the multifocal SCC in 2 lobes with high, very high AFP. So this is pathologist finding when we have the liver resection, and we could have the pathology could show this. You can see that this is the tumor of the specimens, and the microscopic is fully differentiated SCC with RAT3 with large solid trabecular pattern with microvascular invasion, and the resection margin, the nearest margin is just 0.5 cm. On the fibrous cord between the liver and the colon, we have the tumor cells in the vessel lumen and also in the adipose tissue. With the chronic hepatitis B, METAVIR score is A1F2. This is the microscopic of the liver when it has the resection, and the tumor invades to the microvascular at the bottle tract is here. And this is the fibrous cord that have the tumor cells in the vessel. So this is the AFP and the liver function change. On March is the AFP is 175, 57, sorry. In June is 7,000. In July is the 10,000, and in by the end of July is the 13,000, and till now it is 19,000. The AB level increased very much. So we have the MRI and also for the MRI performed recently, which show later on. So with the diagnosis is the recurrent multifocal hepatocarcinoma, happy infection, already treated with systemic therapy, Lenvima, with the TACE, and after that is the atezolizumab, and also some treatment before. So now the question for the discussion is what is the next treatment option, and what can we do further to have the other plan for the patient. For example, we should we perform NGS testing or anything to find out the molecular change for the patient? So this is the case. And Dr. Hui, please help us to share the recent image of the patient, please.
Yes, thank you, Dr. Thuận. Anh Thuận ơi, anh Thuận tắt cái share screen của anh Thuận để em mới share được anh Thuận ạ. Good afternoon, Professor from the Singapore side. And I hope that you all can see my share screen.
Yeah, we can see.
Okay, so I will start with my presentation. I will make a brief review of the images from this patient. We can make sure that this is our patient. So I will turn, after that, I will turn off the patient's information. Okay, now we'll go on to our image and analysis. First of all, we can make sure that we have typical HCC case here with hyper enhancement on arterial phase and washout, and we have fibrous capsule. So we don't have any wonder about the diagnosis, consistent with pathology result. I will skip the arterial and venous phase, and I will go on to the diffusion sequence. And you can see clearly this one, as you can see clearly, this one is from another hospital. The image was taken in June, and on the right side we have our images in our hospital taken in August. As you can see, after both of this image is post-surgery. First, we can see on segment 2. In June, we have a small lesion here, and it's turned out to be very large here. The same goes to segment 3. As you can see, in comparison, they double in the size of the largest diameter. About segment 7, we have clear growth of the tumor, although the largest diameter doesn't increase by much, but I believe that the density of the tumor is quite significant. So in conclusion, I think we have a progression disease here, but because I have heard that the patient is going on immunotherapy treatment, so I think the most compatible conclusion is IUPD, unconfirmed progressive disease, according to the application of the iRECIST criteria. So in my suggestion, I think we should follow up for about 4 or 8 weeks later to confirm the diagnosis. That's the point of view from radiology point of view. I think I will hear from your comments later.
So thank you, Dr. He. So it means that for the recent MRI, we can see that the disease progression, right?
Yes, we have clear progression, but if we apply iRECIST criteria, it is unconfirmed progression disease.
So once again, thank you. So our discussions on here, Professor, do you think that it is on the liver cancer? Can we apply the iRECIST, or we can use the MRECIST criteria for the liver lesions? the first question. And the second question, well, what do you think about the disease progression? And what can we do next? Thank you.
Okay. Hi, David here. I just want to find out from the MRI, are there new lesions seen on the latest MRI?
Here,
Are there any new lesions seen?
có tổn thương nào
I
mới
will.
không? So với lại trước khi điều trị cái
No, I don't see new lesions that newly appeared. They are they are on target lesions and non-target lesions that progress in terms of diameter.
There's no new lesions, sir.
Can I ask you how high was the alpha fetoprotein? I mean, what was the upward trend of the alpha fetoprotein?
Yeah, the AB goes up very, very quickly. Before the treatment is 7, and after 2 months, it is 13. It is 13,000, right? 13,000. 19,000. For the second test after 1 month is 13,000, and now it is 19,000. Before IO treatment is 7,000.
Okay, so it actually is clearly a biochemical and radiological progression. I mean, whether you use M-RECIST or I-RECIST. Can I ask a Charles Pugh status? Is this patient still Charles Pugh A?
Yes, he's Chi A.
Okay.
Chi A, yeah.
And all right, and the other thing to say is that poorly differentiated HCC with high alpha fetoprotein are always a bad prognostic liver cancer player. It's very hard, and a lot of times they don't respond very well to immunotherapy. So if this particular patient is here, I would probably try something different. So, for example, I'm not sure what is your experience with cabozantinib, but cabozantinib is an oral TKI. The study was actually published in the New England Journal of Medicine in 2018 by Ghassan Abu Alfa. It's called the Celestial Trial. And it's a study that was actually done after sorafenib progression and even after IO progression. So in the cohort after IO progression, the feeling is that their response and their benefit is very similar to after sorafenib. Now, do you have a lot of experience with cabozantinib?
No, we don't have cabozantinib in Vietnam.
So I apologize. So I mean, it was very expensive in Singapore until 2022. But just for the theoretical part, it's normally given 60 milligrams per day. But for Asian patients, we normally give it at 40 milligrams because very few people, because Asians are smaller, can tolerate 60 milligrams. And again, just for your fellows' interest, it's an AXL, MET, and VEGF receptor 1 and 2, 3 inhibitor. And if you give that drug, you monitor the alpha fetoprotein. If the alpha fetoprotein of 19,000 drops to a low level within 8 weeks, you have a better survival. Now, so what happens in Ho Chi Minh City, even in Singapore, if a patient cannot afford cabozantinib or there's no access to cabozantinib, the question now is, can you give another IO? I think the answer is I would not give a single agent IO because if you're progressing on a Atezo-Bev, I would not give pembrolizumab and I would not give Opdivo. But I'm not sure what you would give over there because I just feel that if you give a single agent IO, it probably won't be very beneficial for someone who progresses on a Atezo-Bev.
And do you think that we could perform NGS testing to find out some more?
Yeah, it is a good question. So the reality is you and I both know is that there is no specific targeted therapy that is driven by what we call oncogene addiction in HCC. So even if you do NGS testing, my own feeling is that it won't be very useful. That's my own personal feeling. The other question is whether you have ramucirumab there. Do you have ramucirumab?
Yes, we have ramucirumab here in Ho Chi Minh City.
It's worth trying that because, as you know, ramucirumab is an antibody against the VEGF receptor, and it's usually given only if the alpha fetoprotein is 400 and above. And in this patient's case, is more than 19,000. But I'm just going to say something that's not very evidence-based, is that in Singapore, we have published data using capecitabine and thalidomide in patients in Child-Pugh A, B, and even C. And this was a study we published in American Journal of Clinical Oncology more than 10 years ago. So we keep that capecitabine dose a bit lower, not so metronomic, but we dose reduce. And we give thalidomide at 100 milligrams every night. And we have responses. So we actually have not just partial response and stable disease, but we have complete remission. So capecitabine is something I'm sure you have. You probably have capecitabine easily, but I don't know if you have thalidomide. I say that because we have thalidomide and it's very cheap in Singapore. So we use that together with capecitabine.
Yeah. And one more question: do you have any trials recently now at NCC for the patient?
Yeah, I need to find out about that, but I can let you know by email. I will let Tristan know as well.
Yeah.
If the patient is interested in doing clinical trials with us, we're happy to see him. Again, just for update of information, Professor Chow and I were just at Apple conference, and we have a lot of interesting discussions, and we will have APGCS on this Friday, if any of you are keen to attend. But Richard Finn told me that sometimes when he has patients like yours, they have failed Lenvima and they have failed atezolizumab, he tries a combination of two IO drugs, which is either Ipi/Nivo or Tremelimumab. But he says that he has tried a few patients on Ipi/Nivo, and they have responded very well, even after they progress on everything else. So I'm not sure whether you can get subsidized Ipi/Nivo in Ho Chi Minh City. That's also worth trying.
Yeah, thank you for your information. So, any question from our audience? Do you have any question? One more question, because we can see that there are several lesions in the liver, but now we don't see any other lesion outside the liver. So, do you think that repeated taste is good for him or not?
I don't have much experience on taste, but in such cases, we can consider Y90 microsphere therapy, which you can give selectively. That means you can try to target the lesion as accurately and as close to the lesion as possible. The one in the right lobe and the at the edge of the right lobe and also the left lobe, you can try to target them and see whether you can control the disease. So we have tried that before.
Okay, thank you for your information. So any question from our audience, any comment? Thưa các anh chị ở trên tham gia online có câu hỏi hay ý kiến gì nữa không ạ? And then, so if we don't have any question and comments, so once again, thank you for your time for our TB today on SCC. So once again, thank you, Professor To Han Chong, Professor Pierre Cho, and doctors from NCC. Thank you for your time, and hope that in the very near future that we could receive you as our guest in Ho Chi Minh City. And I hope that I don't know why our director, vice director, not come yet, but actually it's run out of time of your time. So we could connect with you via email or our connection via Evelyn Lee, so that we could perform the TB every month. Is it possible, Professor To Han Chong?
Yeah, no, Dr. Tone, we would love to do that. I think also partly if it's purely on HCC, it might be possible, but I would suggest if you are interested in lung, breast, colon, and even some rare cancers, you can let Tristan know in advance because we will have a different team for each different cancer. And that in a way will be easier for our side as well, because then different groups of doctors can come in every month.
Yes. Okay. So, but but you already said about the joining TB with also not only us but all the partnership is in China or
Yes,
as
that's
well.
right. Yeah. We have quite a lot of tumor boards. So in a way, it'll be a little easier for us if you can identify patients for one particular cancer. Like for example, recently we had a session of colorectal cancer. And I think that went very well. So we just focused, and this was with the Philippines. So we had a colorectal cancer tumor board with the Philippines, and they just presented colorectal cases. So we had the head of colorectal cancer on board. We had a medical oncologist who does colorectal cancer, and I do colorectal also, so I was there. And we have radiation oncologist, Dr. Fay. So I think that will work very well because then you have different teams talking to you, which is good, I think, the subspecialization.
Yes. So I could like to have the exact time of the tumor ball joining tumor ball with Philippines and also with China in order to arrange for our TB here could join to share some cases as well.
Yeah. No, that's great. No, we were very honored and we would love to continue the tumor board with you and certainly happy to visit Ho Chi Minh when we can.
Yes. Okay. Once again, thank you.
Thank you so much.
Thank
Yeah,
you very
thank you so much.
Thank you.
Thank you.
Bye-bye.
Yeah, thank you
I
and
will reach out
goodbye.
to you.
Yeah.
I will reach out to you to arrange for our futures tumor board.
Okay. So I will contact with your team at NCC.
Yes.
Yes.
Yes. Okay.
Okay.